Okay, so I'll go ahead and get started. So thanks everyone for attending today. I'm going to be kind of reviewing a couple of ongoing projects, starting with sort of my personal passion project that I'm hoping to kind of set up for a future RCT, and then one that I'm already working on, a randomized controlled trial that I've presented here before. So I was just thinking I could also just review some updates and inform everybody of where we're at now. So I'm a general surgery resident from Canada, and I'm really interested in looking at the addressing psychosocial risk factors in the perioperative period for patients with gastrointestinal malignancy. I'm interested in surgical oncology, and this is something that I kind of want to dedicate my career to as a young clinician investigator. So a bit of background here: patients with GI or gastrointestinal malignancy who undergo elective surgery are at increased risk of postoperative morbidity and mortality compared to patients who undergo surgery for benign disease. Perioperative interventions have typically focused on modifiable biomedical risk factors, and there's really been little work on addressing psychological and social risk factors. So things like behavioral traits, mental health issues, resilience, resourcefulness, and social support, which may have an impact on self-management and recovery in the postoperative period. So in 2009, Leeds et al., this was actually done at Johns Hopkins by a colorectal surgeon who's now practicing at Yale, but as part of his MPH, he did a prospective observational study looking at 142 patients with gastrointestinal malignancy. And his study showed that patients with multiple psychosocial risk factors and medical comorbidities had a 3.4 times the odds of postoperative complications compared to patients with one or no psychosocial risks. And there really hasn't been much else. There really hasn't been too much other work that has kind of investigated this from a mixed methods or qualitative perspective. And so the effect of psychosocial risks on cancer surgery remains understudied, and there is a need to further investigate how psychosocial risk factors might impact a patient's recovery and their self-management in the post-op period. So my long-term goal is step one will be to create a perioperative intervention to address psychosocial risk for patients with GI malignancy undergoing elective surgical resection. Things that I'm personally interested in incorporating, and I've been working with the psychiatrist to kind of learn what some of the resources available are. I'm interested in frequent contact or touch points with patients. So following up with them, maybe like every second day in the week after surgery, and then maybe once a week, once every 2 weeks as time progresses. Another thing that is kind of popping up is social prescribing. So having an understanding of community resources and being able to write a prescription for social support or social services, similar to the way we would prescribe medications. And then my ultimate goal is to create a multi-center randomized controlled trial to evaluate the effectiveness and the implementation of the intervention within the elective surgical setting. And this is kind of I'll give an update on the DECIDE PC study, but I've learned a lot from the current program manager on a clinical trial now that's kind of pairing the effectiveness with the implementation science approaches. And so that's kind of where that comes from. And I'm really excited and eager to work towards this. So what I need to do to get there, or my short-term goals, are first, I need to do studies that are going to inform the creation of the psychosocial intervention. And so I'm currently working on a mixed methods prospective pilot study. We're currently applying for ethics approval, and we haven't gotten our approval yet, but hopefully soon. And then a systematic review that will serve as my thesis under the supervision of Dr. Irvin. So based on these studies, I'm hoping to create the intervention, and then I'll be hopefully doing essentially a pilot study, prospective pilot study to generate preliminary data on the acceptability, feasibility, and efficacy of the intervention. So I'll start with the mixed methods study. So the objectives of this study are going to be to explore how preoperative psychosocial risk influences patients' postoperative experiences and recovery. I'm interested in looking at the association between psychosocial risk factors and short-term postoperative outcomes. Specifically, I'll be looking at 30-day and 90-day complications, mortality, and readmissions among patients with gastrointestinal cancer undergoing elective surgery. This will be a single center prospective observational cohort study at the Johns Hopkins Hospital. We might add Yale as a second site. And then we're really going to use the combination of the quantitative and qualitative methodologies to explore how preoperative psychosocial risk impacts patients' postoperative experiences and outcomes, and try to get almost a deeper understanding, or try to start to understand how this increased risk manifests. In terms of our inclusion criteria, we're going to be targeting adult patients diagnosed with GI malignancy, which we're defining broadly, so upper and lower gastrointestinal tract, who are undergoing planned elective surgical resection, so no acute oncologic surgery, English speaking, and able to provide informed consent. We're planning to exclude patients who have previously been diagnosed with cancer or have previously undergone a major thoracic or abdominal surgery, excluding some of our bread and butter cases in general surgery, like a laparoscopic cholecystectomy, an appendectomy, cesarean section, and things like that. And then we're not going to be excluding patients based on their psychosocial risk factor screening, which will make more sense once I explain what that is. In terms of our sampling strategy, we're going to be using purposeful maximum variation sampling. So we're really interested in having a diverse group of patients in terms of age, gender, cancer type, stage, and treatment characteristics. Based on Dr. Leeds' study in 2009, we anticipate that about 75% of patients will have at least one psychosocial risk factor. And again, we're not screening patients so that patients who screen positive are included and patients who screen negative are excluded. We're really interested in capturing a diverse range of perspectives and experiences. So it'll be pragmatic in this sense. And then we're aiming to target 30 participants. And this is really guided by other mixed method studies in psychosocial oncology, and also the fact that we're going to be performing longitudinal qualitative data collection. In terms of our theoretical frameworks, we're going to be using these frameworks to explore the interplay between psychosocial risk and experiences with physical, psychological, and social challenges faced by surgical patients with GI malignancy. The two frameworks that we've chosen are the biopsychosocial model, which is obviously very, very straightforward, and then the behavior change wheel, which is an implementation science framework. Our study outcomes are really defined by the National Surgical Quality Improvement Program, or NSQIP. So we're using well-characterized outcomes that are frequently used in large national surgical databases to ensure cross-comparison with other surgical oncology literature. Our primary outcome is 30-day complication rate, and then our secondary outcomes are 30-day and 90-day mortality and readmissions, and 90-day complication as well. In terms of our quantitative data, we're going to be doing EMR review at different time points. So after enrollment, we're going to be getting patient characteristics, baseline demographics, medical history, and disease characteristics. And then at 30 days and 90 days, we're going to be doing our post-operative outcome ascertainment through chart review. And then we're also going to be doing researcher-administered surveys at baseline, looking at psychological and social risk factors using validated standardized measures that are well known and well characterized in the literature. And these surveys will be conducted after surgical consultation or on the day of surgery. And this is just a list of the psychosocial risk factors that we're including. So we have depression, anxiety, addiction risk, resilience, self-efficacy, and social determinants of health, using the standardized assessment measures, which are in red. In terms of our data collection, we're going to be doing longitudinal individual semi-structured interviews at 3 time points. So preoperatively before their planned surgery, 2 weeks after discharge, and then 90 days after surgery. Our interview guide will be created using the biopsychosocial model. And then we're really going to be prompting patients to describe key challenges they've experienced in all 3 domains, so physical, psychological, and social, and some other logistical or practical challenges that they may have experienced post-operatively since their cancer diagnosis and then associated with surgery. In terms of our analysis, our quantitative analysis is very straightforward. We're going to do descriptive statistics, and then we're going to study the impact of preoperative psychosocial risk factors on postoperative outcomes using logistic regression models. And then we're going to be reporting the effect size with 95% confidence intervals for our estimated effects at both 30 days and 90 days. In terms of our qualitative, I lost this slide. I was just looking at it before, so it was more rigorous, but I just kind of filled in the blanks. Essentially, we're going to be transcribing the interviews verbatim using a professional transcription service. I've been working a lot with Dr. Jill Ocharzek in the School of Health, Behavior, and Society. So I'm really trying very hard to grasp qualitative research and get a good handle on qualitative methodology to pair with the good quantitative background I'm gaining from the epidemiology CTES track. And so we're actually going to be using a thematic analysis called framework method, which we've been using over the last year on the DECIDE PC study, which really involves a process of familiarization through reading and summarizing the transcripts and then organizing or coding the data. Then we would make an analysis table and chart some of the coded or all of the coded segments that are relevant to the research question, identify themes and categories, and this kind of becomes an iterative process where you have several meetings, come to consensus, and refine those themes and categories. And this is, I don't have really any experience in mixed methods research. So again, working with colleagues in the Health, Behavior, and Society department to on the specific mixed methods design. But we think this will be a concurrent triangulation design where both the qualitative data analysis and quantitative data analysis are performed, and then you're kind of using them both in your final interpretation. So they're performed separately, and then you kind of combine them and come up with your findings based on both results. So that's the first study that I wanted to review, and I was wondering if anyone had any questions or feedback for me. We're still early days, so I would appreciate any feedback.
Any questions or so? I do have one. Could you tell me a little bit more about how you'll incorporate some of the social determinant aspects into that study? Because it seemed, if I read correctly, there's only one tool that will be assessing that.
Yeah, we have this one. So this set of 6 screening tools is the same one that Dr. Leeds is his group is using. Mm-hmm. This really is the only assessment measure looking at social determinants, but I think it might be a good idea to add one. We've been working a lot with the prepare, and I think that might be a better fit here.
Yeah, or maybe even incorporate it into some of the qualitative metrics that you're doing to help gauge your sensitivity for that.
Yeah, that's a great idea.
I think Caleb has a question as well, or comment.
Yeah, I thought this was really interesting. So nice work and well presented. So Thanks. Congratulations. Well organized, like I would hope for from a surgeon. I guess I have at least 2 thoughts. So one is just your focus on GI cancers, and I understand that's where you practice, but I would be interested to know if you think that the issues you're exploring are fundamentally different in GI cancers than in non-GI cancers that are operated upon, and if so, why? And if not, I'm not suggesting you design your study differently, but I just think that's an important question that just comes to mind, like why, like especially if your research is sort of scalable, and if theoretically, if you just opened it up to other surgeries, you could greatly enhance your sample size and your ability to look at subgroups and potentially look at other questions. So I guess one has to do with where you're putting your fence boundaries. And then the other is, to what degree are these concepts that you're interested in time variant or not? And I guess to the degree that they are, that makes things a little messier. And I guess I was just curious if you had thoughts or concerns about that. If they're not and they're fixed, then fine. You measure them a month after surgery and maybe nothing changes. But if you think about something like self-efficacy, I don't know if it is on your list. Yeah. So like if you have a big surgery, maybe everybody comes to town and people send you flowers and there's a food train that's organized for you if you have a Whipple or something.
Yeah.
And, everybody's bringing you stuff, and you can imagine it's possible that someone's feelings about self-efficacy are world different a month after surgery than a month before surgery, and they might bounce around a lot. So I'm just curious what you think about the degree to which these are time varying or not.
Yeah, so those are both very good points, and definitely important for me to think about and bring back to the research team. I think to answer your first one, the GI malignancy was really almost like a selfish inclusion criteria, because these are the patients that I have access to. I was worried about just my capacity, given that we'll be doing interviews at 3 time points with 30 patients. That's 90 interviews. And so I kind of didn't think that I could reasonably tackle more than that. And I worried a little bit about, I wanted to have my maximum variation sampling kind of touch on all the different cancer types. And so I think for me, it was the fact that I'm in general surgery, and then just what I think is feasible for me at this time. But certainly it is possible that this could be translatable to other cancer types. And then the other thing is just the symptom profiles for GI malignancy postoperatively, I think would be very, like the fatigue and pain and things like that are pretty general, but then bowel related issues, nausea, vomiting, that kind of stuff. Again, they're kind of different symptom profiles in the post-op period. So I think that those are my answers to that first question. And then in terms of your second question, certainly that is an important consideration. We were planning on just doing this at baseline, and then trying to see how the baseline screening or the presence of some of these psychosocial risk factors at baseline impact their recovery. And so I do suspect that these would be time varying. But I think, and I don't know if I have like the best answer for this question, but I think I think we would probably get different results if we did this at the 3 time points. But what we're really trying to understand is if someone's baseline psychosocial risk factors influence how they recover and how they do in the postoperative period in a more longitudinal sense. But
are these outcomes or exposures?
These are going to be exposures.
But are you, yeah, so okay, but you're measuring them both pre and post-op.
We're measuring the psychosocial risk factor screening is just at baseline.
Oh, only a baseline. Okay.
Our qualitative data analysis at the 3 time points.
Gotcha.
Yeah. But I really appreciate the feedback. Those are great.
Yeah, I mean, you don't have to do the perfect study, right? Because that hasn't been done yet. So it has to be good enough for your purposes.
For sure. Thank you. And then I see one in the chat. Oh, just a direct message. Okay. So then this is the second part of trying to understand and create my own intervention. And so this will serve as my thesis, and I've been working with Dr. Irvin on this. So very similarly, my research question is, are psychosocial interventions effective at improving outcomes in patients with gastrointestinal cancer undergoing elective oncologic resection? And so this is just really to see what people have done and what has worked and what hasn't worked. We're including psychosocial intervention as any intervention that aims to improve the overall quality of life of patients, addressing psychological and social factors that may impact their health and well-being. What this translates to, and we're currently in the search strategy phase, and there's just an abundance of literature on psychosocial interventions specific to oncology, but there's really not much that we're seeing for surgical patients specifically, and interventions in the perioperative period. But things that we've seen are psychological support, so counseling, things like CBT, social support, skill development. Education is a big one and a huge category and an overwhelming category. Advocacy, community integration, crisis intervention, and rehabilitation. I'll talk about the search strategy in a couple of slides, but we might need to narrow this down a little bit because right now that concept is just massive and it's getting us too many results. And so if Dr. Saldana is in this call, I would like to give him a shout out because this is like straight from his class. And I learned a lot from taking that course with him. And I go back to those slides all the time. But my PICO question here, just mapping it out. So population, we're looking at adult patients with GI malignancy, again, including both upper and lower gastrointestinal organs. Intervention is psychosocial intervention to capture the perioperative period. We're thinking 2 months, within 2 months of elective oncologic surgical resection. The comparison is going to be no social intervention, or we'll also probably include studies that are comparing to psychosocial interventions. And initially I had quality of life as my primary outcome. And then Dr. Johnston, who's my supervisor within the School of Medicine, felt that we should just keep it very broad and probably come up with our data extraction sheet and solidify the outcomes once we see what's out there. But interested in looking at quality of life, self-efficacy, patient activation, some of the mental health outcomes. Yeah, and then some of the harder endpoints too, like mortality, complications, morbidity, and things like that. Because this is a therapy question, we're going to be targeting clinical trials and cohort studies. And then the intervention will have to be 2 months within 2 months of the planned surgical resection, and then outcomes evaluated within the year. The setting will be elective surgical practices. We're going to be focusing on English language studies. And right now we want to have our cutoff as the year 2000. Again, that might change depending on how many studies we end up with. So I've been working with Lori Rossman, the School of Public Health's librarian, and she's actually been letting me kind of like run with this search, which is a great learning opportunity because it's for my thesis. So my first concept is cancer, and this will be related to population. So we've identified some mesh terms and then also keywords, and this will be kind of concept 1. Surgery is my other concept, also related to population, also outline some mesh terms, a lot less keywords because I think there's really not much variability in the way that we talk about surgery or operating. And then, oops. My third concept is a bit of a mess. Oops. So psychosocial intervention. So I pulled these mesh terms, and then we used these keywords, and there were like just millions of hits. And so right now I'm trying to, we don't think the problem is coming from the mesh terms, but I'm trying to better delineate the keywords here. Really to have more of a narrow focus. And like I said, it's possible that we'll need to focus on like a specific type of intervention here. And so Dr. Irvin's helped a lot with coming up with the research question and reviewing it. And our plan is going to be to finalize the search, and then we'll start with the title and abstract screening. So that's number 2. Any questions or comments? Dr. Irvin, I don't know if you wanted to make any points or clarifications or anything like that.
No, I think you summarized everything really well. I think it would be interesting if you just take a few seconds for the first-year students to talk a little bit about your choice of a systematic review and why you think that might be a good option, and how it's going so far in terms of managing their time and things like that. Just very briefly, because I think that's helpful for the first-year students.
For sure. So I think what's really been important for me is like thinking about my long-term goals. And I've had incredible mentors who have kind of enforced that in me and been very supportive. And so when thinking about, we're in the clinical trials and evidence synthesis track, and obviously it's not possible for any of us. I came in with this like crazy mentality of like, I'm going to do an RCT because I've seen other surgical residents pull off these RCTs in their 2 research years. And kind of coming into this program, I've understood that, there's a lot of preparatory work that should go into a randomized control trial to make sure that it has very robust and rigorous methodology, and that the quality of the RCT is appropriate, and that you're actually contributing something good to the body of literature for the topic that you're interested in. And so I think a systematic review is a really good place to start, just because it'll help you probably, if you have something you're interested in and you can think of an intervention that you might want to study in the future, it's a good place to start to see what's available and kind of start planning and charting I think it's never too early to start your research career and kind of identify an area you're interested in and see what preparatory work you need to get done by the time you can before you want to start your randomized control trial, or before you end up maybe in a staff position somewhere where you have resources to do that. So it's kind of like my rambling answer. I don't know if anyone else, any of the second years here or the PhD students have anything to add.
No, I think you summed that up really well. And I think also considering third term, right? So the choice, you took the decision to take the systematic review course in your first year just because you already thought through the idea of doing at least one systematic review during your term. So that's another consideration for students who might be thinking in that direction as well.
Yeah, I would definitely recommend that. Sorry,
I
Dr.
just had a question and a comment.
Yeah.
One, I think there is a growing school of people that think that every randomized clinical trial should start with a systematic review. So yeah, that seems a really appropriate project. And my question is, you said in your search you're coming up with too many studies. Have you thought about limiting it to only randomized clinical trials, and what is your thinking around that?
That's a great point. I think initially we had thought, just because it's a therapy question, of also including cohort studies. But I think that would actually be a really good approach. I'm sure that would really limit it down, because one of the reasons why I'm passionate about this type of research is I find, and I've spoken to a couple of you, I think, about this, but I find applying the rigorous methodology that we're learning in epidemiology is often lacking for some of these these interventions more focused on psychological and social risk factors. And we've talked previously in journal clubs about outcomes like quality of life maybe not being appropriate, or not as appropriate as harder endpoints. So I think these are all kind of considerations when thinking about RCTs in this field of study, where maybe these types of interventions have traditionally been evaluated through quality improvement or patient safety programs. So I think that would probably really narrow us down, and that's a really great input. I'll take that back to Lori for sure. But yeah, that's kind of one of the reasons why I'm interested in becoming a methodologist in randomized controlled trials, really related to like educational interventions, informational interventions, things like that, from my own experience, I think are really lacking. I don't think we do as good a job as we think we're doing with patients on an individual level. And so, yeah, again, rambling. Thanks, Dr. Holbrook.
Oh, you're welcome. Sounds like a great project.
Thank you. And then, do I have time to review one more thing?
Sure. Since I'm the next speaker, I yield you the time.
Okay, perfect. Thank you. So I just wanted to give an update on where we're at with this study, which I've presented previously. And I actually got feedback from this group and did talk about it with Dr. Johnston, and we've since, based on that and based on a couple other data points, we've made some changes to our study and our study design, specifically our outcomes. But this is a program, this is a study that Dr. Johnston is leading from the School of Medicine, really addressing some of the health disparities related to the access to palliative care services among African American patients with cancer, with advanced cancer. So I've taken on the program manager role this year, working very closely with a research coordinator, our lead community health worker, and Dr. Johnston. A bit of background here is that there remain persistent racial disparities in the access to and utilization of palliative care. The literature has shown that African American patients are less likely than white patients to access or receive palliative or hospice care, have documented advanced care planning discussions, achieve adequate symptom control, and receive goal concordant care. So one solution to this has been the implementation of community health worker programs. So CHWs are non-clinical public health workers. They've been implemented in a multitude of settings and diseases. More specifically, we're seeing a lot of programs popping up within cardiovascular disease. They tend to help patients from high-risk communities overcome barriers in access to care and address social determinants of health. And they do this because they usually come from the community they're serving, and they have a deep and nuanced understanding of the communities that they're serving. So Dr. Johnson and his team did a prospective pilot study that was mixed methods, and they generated some preliminary data on the feasibility and efficacy of the intervention. So that led to this R01 NIH funded study, essentially, that aims to assess the effectiveness of the CHW palliative care intervention, specifically for African American patients with advanced cancer and their caregivers. And then this is the implementation piece that I highlighted before, just developing generalizable knowledge regarding the influences of contextual factors on implementation. And this is something completely new to me, and I've actually added the implementation science certificate, which I think was added over the summer. But when thinking about some of these interventions, it's also important to think about the future and broader implementation and future scale up. And so this is kind of just to gather information on how this might go in the future if it's found to be effective. So these were the three aims of the study. We just completed aim 1, which was to refine the DECIDE PC intervention. So we did 25 key informant interviews. We did 6 patient and caregiver focus groups. We formed a community advisory board because we're trying to incorporate community-based participatory research principles. And we're kind of in the process of evaluating all of that and coming up with a couple of publications related to that. This was also something that I've kind of realized along the way in working on this RCT. I think when I joined this team, I thought, wow, this is going to lead to a publication in like 5 years. But really, like, we've been able to maximize our productivity in terms of the data that we have. And so again, kind of just thinking about my research trajectory is like focus on the long-term goal and what you need to do to get there, and just maximizing productivity along the way. It's really kind of amazed me with the skill set that I've gained from this degree so far, what I've been able to accomplish in the projects and teams that I've been a part of. So we've actually just started recruitment and enrollment. So that's aim 2 is the RCT, where we're going to be comparing the effectiveness of the DECIDE PC intervention relative to an enhanced standard of care pathway. And today we're hoping to recruit our first patient who are meeting in clinic. It's a hybrid type 1 randomized effectiveness and implementation trial, multi-center, pragmatic, parallel group, assessor blind. We're randomizing patients to the intervention or enhanced standard of care, and our intervention will be a total of 6 months with remuneration for both the patient and the caregiver. These are the 3 sites that we're implementing the intervention at. We're looking for, like, the criteria are very pragmatic. So we don't have like 10 to 15 eligibility criteria. We're really looking for African American adults who have advanced stage malignancy. We're looking specifically at solid organ malignancy. The big one here is no palliative care experience in the last year, because we want to see if the intervention helps improve access to palliative care. And then we're also looking for caregivers, so anyone providing informal unpaid care to an eligible participant, and not identifying a caregiver will not preclude a patient from participating. So these are our two pathways. So the CHW intervention with the standard of care, and then our enhanced standard of care pathway is a palliative care brochure plus standard of care. The palliative care brochure is something that we created as a team with input from the community, specifically African-American patients who had experienced cancer in the past or were currently undergoing treatment. The intervention, I've already talked about this, but essentially our intervention is geared towards the CHW meeting patients where they are. And so they're not confined to the hospital. They actually go out into the community. They perform home visits. They do regular telephone check-ins. They might attend clinic appointments, refer patients to community resources. From a palliative care perspective, they've been trained to educate patients on palliative and hospice care, and address some of the stigma or some of the mistrust in the healthcare system, and then also facilitate advanced care planning discussions. This is our trial flow diagram. I won't go into too much detail here. We're aiming to enroll 160 dyads, and at Johns Hopkins, we're hoping to enroll 65. We're allowing for over enrollment, but we had a lot of difficulty accessing these patients as part of AIM-1. And so we just changed our numbers based on changing our primary endpoint. So this was the feedback that, I don't know if you all remember, but I received feedback after presenting to this group. Our primary outcome was quality of life. And then the feedback was that like a harder endpoint might be more effective. And so we actually reviewed the literature and found other studies that used advanced care planning as a primary outcome. And we've since changed that to our primary outcome. And again, being very pragmatic in how we capture this. So we're capturing it through researcher administered surveys, as well as from the community health workers. Sorry, my slides are freezing. What's permitted for patients enrolled, pretty much usual oncologic care. We don't want to get in the way of that. An oncologist may refer patients in the enhanced standard of care pathway to specialist palliative care as they normally would. We don't want to prevent patients in the control arm from getting palliative care. We know it's beneficial to them, which is why we created that patient brochure, and why we have specifically told the oncologists not to change their management. And then we're kind of taking this on a case-by-case basis of patients are prohibited from participating in any other studies that are evaluating CHW support, and then palliative care trials we're kind of taking on an individual basis. This is just how we're identifying eligible participants and screening and enrolling. And then this is just to kind of showcase, this is the last slide I have, just to kind of showcase some of the work that we've done. So like I said, for AIM-1, we've done a ton of work. Last year I served as a volunteer on the team, and I was responsible for creating the CHW training. And so we've since written that up, and we've added a research project around that. And then we've done a lot of data collection, which we're currently analyzing and trying our best to implement any recommendations that have come up through the key informant interviews or the focus groups. And this is just to kind of show, like I was mentioning, the productivity and just being able to maximize your productivity based on what you've done. So last year I felt like I was working so hard on the coursework. And then I was also serving as a volunteer on this project. And I was like I felt like I wasn't really doing much. And then this year for the first year students in your second year, you're really going to have that opportunity to put all your skills together and really produce things that you never thought you would be able to. So that's just to kind of showcase some of the things that you might be able to do with the skill set that you acquire. And that's all I have.
Great, thanks, Olivia. Any questions before we switch over to Dr. Holbrook? It's an impressive amount of work for a second year.
Thank you.
All right, why don't we switch over quickly? We have a few minutes left.
Okay, I will try to make this quick. I'm
Jenna, I think you're muted. There you go.
Yes, thank you. Present a couple of ideas for uh, thesis projects for um, both an MHS or an SCM student. Um, They are both analysis projects, so they're both based on studies that have already been done, that there are potentially additional questions that can be answered. And the first one, which really dovetails quite well with Olivia's presentation, is really focused on looking at patient-reported outcomes and analysis from a cohort study that we conducted a few years ago, trying to evaluate different questionnaires as possible outcomes for a clinical trial of interventions for chronic cough. And the second one is more of a combined analysis of prior trials. And I'll talk about the details of that in a minute. And all of these studies were completed by the Airways Clinical Research Centers. That is a group that I've been working with since 1999. We've done a number of studies. We started as an asthma research group, and we have branched out to do COPD studies. Elizabeth Sugar is leading our effort as a data coordinating center for a lung health cohort study. So we're even wandering away from clinical trials, but it is a very dynamic group that I've just had, it's been a privilege to be a part of. So the first one I was going to talk about was an idea of looking at data from this study that the acronym was COCO, the cohort study for chronic refractory cough, and focusing on patient-reported outcomes. And just as you should be well aware, you know, a patient-reported outcome is kind of can be a broad definition. It can be spontaneous adverse event reports or spontaneous reports from participants, but usually in the context of clinical trials, we're looking at information we gather from participants either in follow-up interviews. We all didn't realize it, that we were doing patient-reported outcome research for years before it became a thing, because we were asking participants questions. But there's also kind of a more standardized by doing daily diaries or periodic diaries and then questionnaires. And really what I'm going to focus on here in COCO is we did a lot of questionnaires, which seem to be the gold or a gold standard for patient-reported outcomes. I'd be interested in input on that. And as you probably are all aware, the development process for these questionnaires can vary quite a bit, and the emphasis of the questionnaire, whether, especially in airways research, sometimes they're specifically focused on symptoms, others can be more on quality of life, how are you doing on your activities of daily living. I also have done a lot of vision research, so they can be involved in you know, specific things about vision. So there's a broad map, and I just put an example of one up there and cited a few that we probably all come across. And Olivia had a few of the mental health indices that we commonly use in our trials as well. So for COCO was part of an R34 planning grant. So that was a grant to the NHLBI, and we had an idea for a clinical trial that we wanted to pilot, which was zinc supplementation for cough. And So we did do that trial. I don't think, we'll see. Let me see if I can just briefly show you a little bit of that trial that we have published. It was, uh, I don't know if you can see that very well. Maybe I can make it a little larger.
Yeah, a little bit larger might be good.
Yeah, so there, there's the consort diagram. It was indeed a pilot study done at a couple of centers. And we only ended up with 34 participants. But what we were specifically looking for was any signal on these questionnaires regarding whether we should proceed to a larger study. Um, and when we looked at what our primary outcome was, and it was funny, I had to go back and really think about this some more as I was preparing for this. We looked at this CQLQ, so it's a cough quality of life. And you look at this data and, it's a small group, but, it almost seems like, the zinc is the more turquoise versus the gray, and there's the score is along the y-axis, that there does seem to be some suggestion of a benefit. And noted we followed them, or they took the study intervention for 6 weeks, and then after it was stopped, this is the washout period. But regardless, when we went on to think about doing a large randomized clinical trial, the difference that we observed in any of these outcomes between zinc and placebo, we used a rule or a criteria to proceed to a full-scale clinical trial, was that if our 95% confidence interval for the difference would exceed what was considered the minimal clinically important difference. And the differences I just showed you did not. And so we did not end up proceeding to the clinical trial, which is probably part of the reason that now we are we haven't analyzed the data or put a big emphasis on the analysis of the data from the cohort study that we conducted across all the centers as a strategy to say, okay, this demonstrates that if we are going to go on to this clinical trial, that we indeed can recruit this population, evaluate zinc, and there were some concerns about potential problems with copper status if you're supplementing people with zinc, and also validate and refine the patient-reported outcomes. So we have done some analysis of these data, but really haven't pulled it all together in to a publication or potentially a master's thesis. But there is a basic analysis plan that, as part of this project, it would be important to complete. But there's certainly room for other questions that could be addressed in these data. But we want to evaluate those cough questionnaires, and as I noted, there were a number of them that we used, and estimate how they're related to each other, and also the patient's subjective reporting of cough. We didn't have a cough electronic monitor, and estimate how they could potentially be used in future clinical trials, and potentially other questions. So the cohort study was fairly short. It was only 4 weeks long, but we did get about 120 people, and we do have data on a number of questionnaires, and we can evaluate the reliability of the questionnaire, and we can also look at them in comparison to cough diaries the participants kept. But basic premise of the study would be to be evaluating these cough questionnaires and to see how they should be used in future clinical trials. I think a student would obviously need to be familiar with some analysis programming. One advantage of this project is or advantage or disadvantage, there is a basic, outline for how to analyze these data. We have a protocol, and we have done preliminary analysis, but that doesn't preclude coming up with other questions. And I think you could would be a contribution to how these questionnaires are used in clinical trials, and especially specifically for chronic cough. And I think it's definitely a publishable thesis, and potentially more than one publication. Just are there any questions about the COCO project that I could answer quickly? I want to try to go over both projects and have about 7 minutes, but I'd be happy to entertain some questions now.
Janet, I was just wondering if you can provide some materials. I can post them for the students also in the shared drive so they can have a chance to read through when you're done.
That's a great idea, Anne.
Yeah.
I could,
Yes.
yes, I will do that. I have the protocol, and certainly the Zico paper. Yes, I will do that. So the second question is based on uh, a drug that we had studied in 3 clinical trials, which is montelukast, also known as Singulair, was developed by Merck as a treatment for asthma and allergic rhinitis. And it was approved some 20 years ago. And it is it was a real advance in terms of asthma, or a benefit in terms of having oral agents, because as you can probably imagine, um, adherence to inhaled corticosteroids or inhaled medications is more difficult than in adherence to oral agents, and adherence to chronic medications is problematic in itself. So montelukast does fill a real niche. Merck submitted a labeling supplement adding tremors and depression and potential suicidality in 2007. And some of that was based on a case report or a adverse event reporting from, I think, a 15-year-old asthma patient who committed suicide. But they did review most of their randomized clinical trials, and they didn't see any strong signal for neuropsychiatric events. But along with the FDA, they came up with a precaution to add to the labeling that physicians and healthcare providers should be tracking people's mental health status and be aware that this is a potential problem with the drug. Interestingly, I think it was in this 2007 review of over 9,000 patients that had participated in randomized clinical trials done to gain regulatory approval, they had one case of suicidality. And I think it was associated with someone randomized to placebo. In 2013, Merck proposed a partial over-the-counter label to the FDA for adults with allergic rhinitis, but that was not granted, partially because of the concern about potential depression and suicidality. And so they wanted it to remain a prescription drug. And there's been continuing concerns about Montelukast as since 1998. And in fact, there was another FDA expert panel convened in 2017 to review a study done by the FDA on their Sentinel database, also studies based on their adverse event reporting database and the published literature. As a result, that committee recommended not to change the label or to add any warnings, to add additional warnings to Montelukast. Nonetheless, in 2020, the FDA did add a stronger warning, a black box, and changed the indication for allergic rhinitis, that it should be sort of a after patients have failed other treatments, that they should think about Montelukast. So there's continuing controversy about this drug. Despite from a review by the FDA of really strong evidence of to indicate that it is associated with suicidality or depression. And back in, I think, 2008, after the first labeling change, we went back and looked at 3 of our trials that involved randomization of participants to Montelukast in a masked fashion. And I think I can't add this up very quickly, but we had some 700 patients across these studies, some of them with not very long follow-up, and that's been a criticism of most of the studies that have looked at this. But we found no indication from the questionnaires that we were looking at that there was any difference between the treatment groups when in these masked randomized trials. We also had a little additional information in the tape trial, and found even that there might have been a potential benefit associated with Montelukast, admittedly post hoc, and these were not at all questions that we had developed before the studies were designed or as part of the design, because these studies were implemented before the first warning was added. But that's their strength and their weakness, because there wasn't a lot of information out there indicating that these were Montelukast was a drug that led to suicidality or depression. There wasn't any preconceived or biases. So we had have these data from these 3 clinical trials, which we did publish some on the questionnaires. But it has occurred to me more recently that these were randomized clinical trials that had data monitoring boards that followed them. We had serious adverse event reporting systems. We asked participants at every interview, were they having any of side effects? And we had a list of side effects, sometimes that include mental health symptoms that might be related to mental health, like sleeplessness or nervousness, etc. And although I have not gone through all of those data monitoring reports and looked back through those data in great detail, I don't think we had any signal for a reason to be concerned about Montelukast. So what is my thought is that there could be a more systematic post hoc analysis of the data from those three clinical trials to look at the symptoms that were reported over the time that were gathered in a massed fashion, and we had baseline data so we could look at treatment emergent symptoms, to also look at the serious adverse event reporting that went on through those trials. The thing I remember from the LOX trial is there was a lot of concern about pregnancy, and one way to solve infertility may be to do a lot of pregnancy testing. There was a lot that the Data Monitoring Board discussed around pregnancy testing for that particular trial, but we have these reports, and a qualitative aspect of a potential project could be to be looking through those reports and the minutes from those meetings to see what an independent board of reviewers were thinking about as they reviewed these data. From a student perspective, again, there needs to be a familiarity and develop expertise in analytical programming. As opposed to the first project, there really isn't a defined protocol for the analysis that I'm suggesting. And you would need to harmonize the data from the three studies, which is probably both easier than you might anticipate, since it was studies conducted by the same group, and we use, built on the forms, the data collection instruments, and used a lot of standardized data. But then it's always more difficult than you anticipate too, because of different timing and things like that. And it would definitely need to lean on some of our expertise in synthesizing data that we have in the center, not particularly mine. And I think it would probably lead to a publishable thesis project, at least one. So I'm open to answer any questions now. And I would suggest to any of the first year students, or if you're a second year student who is in search of a project at this point, that you talk with your advisor and see if these might be good projects for you. Again, Anne had a great suggestion, and I will send her materials to post, and we can put them in the 2 folders, and you can contact me to ask about what might be involved as well. So thanks, and sorry to be a little bit over time, but I can hang out for a few questions if anyone has them.
Thanks, Janet. Anyone have any questions for Dr. Holbrook before we adjourn for today? Okay. Next time we'll be hearing from Li Xuan, and she's going to be hopefully discussing a little bit about her dissertation. Thanks, everyone.